Okay, we are live.
Terrific. Welcome everybody to the June meeting of the Oversight Council. We have a good agenda today and a nice full house. We'll start with the minutes of the March 22nd meeting. I assume everybody has had a chance to read them. And of course, because we are on Zoom, I will have to do a roll call of names. Is there any point of discussion on the minutes? Hearing none, I will do the roll call. Let's see who there. Laura Adams.
Yes. Yay.
Rob Birmingham.
Yay.
Ray.
Yay.
Lauren Peters.
Yay.
Niels.
Yay.
Cassandra.
Yay.
Sandy.
Yay.
And I also approve the minutes. Terrific. Well done on the first agenda item. Now, we are going to turn it over to Ray for the Executive Director's report. There are a number of interesting issues, particularly ABCD update, which lots of us pay attention to, as well as finance and a review of our publications. So Ray, do you want to take it over?
Great. Thank you so much, Faye. Appreciate it very much, Chair Donahue. Welcome, everyone. Thank you for your time and attention this afternoon. Alex, if we could go to the slides. Yes, there we go. The first item in the Executive Director's report is the finance update. And as promised, I've been wanting to give more information about CHIA's finances in recent meetings. And so I wanted to continue that trend here with a bit of more of a deeper dive on some aspects of our finance, in this case, where our personnel, where we spend or where we allocate our personnel. So this first slide here, this actually I showed last fall. This compares CHIA's FY16 budget to the current FY22 budget. Now, we're still waiting to hear what our FY23 budget will be. FY23 starts in a couple of weeks, so I can't report to you on that right now, but I thought it was useful to bring this slide back up, which compares CHIA and FY16, which was the last year before the CHRTIF, with FY22, which is this year, which is the first year after the CHRTIF, and compare how the agency's spending has changed. And what you'll see is there's a slight increase in the proportion of our spending taken up by payroll, which is the green slice. It's now slightly over 50% from having been slightly under 50%. Other than that, the biggest change is that we had a $3 million reversion in FY16. FY22 is not over yet, so we don't know exactly what it will be, but will be quite small. We're much we work much harder to manage our spending, and so we'll have a very tiny reversion this year. You do see $2 million in debt service. That represents the repayment that we've begun for capital expenditures that we use bond funding for during the CHRTIF years. If you took out that $2 million, our FY22 spending would be essentially level, or actually slightly below our FY16 spending. So we've been, effectively level funded over a 7-year period. All right, if you could go to the next slide.
Great. For those of us
Sure.
that don't remember all the details, or some new people that may be listening, can you remind us quickly, reversion and why debt service now and not in the past, like 2 sentences?
Sure, absolutely. So reversions, that's at the end of the year. If you underspend your targets, the money that isn't spent reverts back to the general fund. And that was an issue, something that CHIA had a bit of an issue with in the past. And so in FY16, there was $3 million that at the end of the year, the agency didn't spend from its appropriation. So that's the story with reversions. Debt service, CHIA historically has not used capital funds for capital assets. It has used operating funds. During the CHRTIF years, one of those strategies, in addition to steep budget cuts, one of the ways we made the CHRTIF payments was by working with ANF and with the full knowledge of the legislature, using capital funding for certain capital eligible expenditures that freed up enough funding for us to make the CHRTIF payments. But with that came these debt service payments. This wasn't, many times agencies use capital funding and the state repays the debt. In this case, this was what's called agency funded debt that we were using. So there's a $2 million debt service line in our budget for the next few years.
Terrific. And this is over 7 years, which I also want to remind everybody, so you don't say, oh my gosh, payroll's up by 20-something%. It's 7 years.
Exactly, over a 7-year period. Any other questions on this kind of the distribution between the categories? All right, Alex, could you go to the next slide? So the other thing I wanted to do was to give the Oversight Council some sense of where CHIA deploys its resources, kind of our people. As you just saw, the kind of the largest chunk of expenditures that CHIA, or the largest portion of CHIA's expenditures goes for personnel. This chart shows you where functionally CHIA's personnel are allocated. This goes by head count. You could also do it by expenditure. I don't know, well, we'll have to do that analysis and report back if there's anything, any interesting differences, but this looks at it on a head count basis. I should point out this assumes all open positions are filled. So this is not our current head count. This is kind of the maximum theoretical head count. It also includes, for instance, in the red bar in the center, the bottom one, provider finance and pricing, there's a dozen, between 12 and 15 people that are fully funded by the Executive Office of Health and Human Services, the Mass Health Program. They show up here as FTEs because I wanted to give you a sense once again of where our people are and what they work on, but that actually isn't on CHIA's budget. So as I said, this kind of overstates CHIA's headcount in some respects, but it gives you a sense of where we, kind of where we place our chips. So it really starts on the right-hand side of the screen. Data intake and data operations, that's really where, kind of our work begins, is when we ingest data. So we have 23 people dedicated to that. The lighter bar ahead, on top of that, this has definitely grown over the years. I think this probably would have been roughly the same size as the bar beneath it, maybe just a bit bigger. But as CHIA is doing more and more, it always starts with more data products. When our analysts always use, for our own internal work and also for external work, it always starts with creating and then supporting a data product, QAing it, all the work that goes into creating data products that analysts then use. So that's a very large piece of what we do. And I think that's a good use of our resources. It shows that we're supporting our own analysts and external analysts with data products. And then the last piece of that is data privacy and security. We have 6 people that are specifically devoted to our data privacy and security work. Some of those people are in legal departments, some of them are in other departments. You could, in theory, consider that administrative spending, but it's so integral to our data operations that I thought it was fair to put in that column. Any questions about our data operations and technology spending, from a personnel perspective?
Could you remind us how many people are employed altogether and in each area?
I think we have about 100 and just over 150 people right now on staff, but there are some vacancies. So it's probably, I think the full complement is slightly over 160, but there is a scale on the left. So you can see the data operations and technology is just over 70 people. And then the next bar, the analytics, it's just under 65. And then the administrative one is just under 40.
Thank you.
You're welcome. So looking at analytics, this is broken out into really we have 3 major analytic teams, and this reflects that fact. Plus we have publications and communications added to this stack as well. So starting at the bottom, provider finance and pricing, that's really 2 teams. Provider finance is the team that we take in lots and lots of financial information from all types of provider organizations in the state, hospitals, nursing homes, community health centers, adult daycare centers, many different types of organizations. We also do pricing work for Mass Health using a lot of that same financial data. So a significant body of expertise, 25 people that are focused on provider finance and pricing analysis. Above that, health informatics and reporting, that's our team that works largely, but not exclusively, with aggregate health plan data. This is where our annual report comes from, our measurements of total healthcare expenditures, total medical expense, relative price, lots of other things like that. So a bunch of important work going on in health informatics and reporting. And then our research and survey team does both our 2, soon to be 3 surveys, but then also some of our more advanced analytic work involving more clinical expertise, things like hospital readmissions and the role that social risk factors play in hospital readmissions, things like that. Lastly, as I said, I included in this stack our publications and communications team. You could, in theory, consider that administrative, but really without that, all that analytic work doesn't get to the outside world. So I thought it was fair to put it into that stack. So anyway, that's kind of the rough division of labor that we have in our analytics teams. I don't know if there's any questions about that. And then if not, kind of the last set of bars to the left is our administrative expenses. Unlike typical executive department agencies that use EOTSS for their technology services, we we're not serviced by EOTSS. So we have 16 people that provide our kind of IT infrastructure, desktop support, networking support, things like that. As I said, that's distinct from the data operations and technology teams that are shown over on the right-hand side. And then also the administrative, because we are a state agency, there's a certain amount of legal, finance, HR work that is also done. So anyway, as I said, the point of this is that in expanding on our financial reporting for the Oversight Council, the biggest chunk of what we spend is on salaries, and I thought it would be a good idea to give you some sense of the distribution of where our personnel are deployed.
Thank you.
Any questions or comments? Okay, hearing none, then why don't we go to the next slide, Alex? This is just a quick update on the APCD, and then we'll move on to Emma's presentation on CHIA's publications. Actually, I did want to say on the finance report, I had meant to mention at the very beginning that since the last meeting of the Oversight Council, there was the statutory annual public hearing on CHIA's budget, which was, several Oversight Council members were there. It was uneventful, so there's nothing really to report on that front. Okay, in terms of
just a quick question on, you talked about vacancies, that how is it going vis-a-vis the challenges of staffing? Are we experiencing the same thing that the rest of the country is experiencing? How's that going?
Oh, it's a great question, Laura. Yeah, it's it's funny, for quite a while we seemed to have very low turnover. It was really remarkable. It was just great retention, and then starting with the pandemic, that continued because I think everybody was sitting tight and wanting to see how things have played out. And then we are now experiencing kind of what the rest of the country is, which is we've seen in the last 9 months or something like that, 12 months, I'm not sure, increased turnover, which is leading to increased vacancies as it takes time to to fill them, and it feels like a more competitive environment. So yeah, it's gotten a bit tougher. I think the people that have left, a very high percentage of them are people that we hired during the pandemic. Just an interesting data point that people that we never met in person were the people that were most likely to have left over the past 12 months. Not sure that there's a connection there, but it's a correlation. So yeah, we are down a number of positions. I think we still have a very good draw or a good story to tell job applicants. So I think we'll ultimately be successful, but it takes time, and then of course it takes management focus to fill vacancies.
Yeah, I'm not surprised that CHIA didn't escape the national trend. I don't know of anybody that has so far. So
exactly, and we're just now getting back to the office, so we're going to have to see how that plays out in terms of people did relocate during the pandemic, and some people are more committed to remote work only, which we're not going to be allowing. And so yeah, we're not done seeing the kind of the shakeout of the pandemic's impact on our workforce.
So you may plan on speaking about this later, but two questions that arise, I think, for the council. One, is there any critical position that's open that you're worried about? And second, could you let us know when people are coming back to the office? And I assume they're not now, since we're all on a Zoom call.
Exactly. Well, so maybe to take the second one first, we're committed to returning to the office. One of the things we've been waiting for is that Suffolk County has been rated high community transmission by the CDC, and because we have so many people that take public transit, and for a variety of reasons, we didn't think that bringing people back into the office during a high transmission period made sense. But Suffolk County just changed to low, and we're going to be back in the office next week. I guess I'm pre-announcing that a little bit. I don't know if the staff has been told, but Suffolk County, we're largely pivoting off of Suffolk County, and then it's more now the details will be whether any of the mitigation or other measures that we'll take, in addition to that. But so we've wanted to return, we've been eager to return, but we felt that a high community transmission rate as a public health agency, it was best to wait it out. And we did have one day that we were back in the office, and then Suffolk County went high. So it, we've been just trying to wait for the numbers to cooperate with us. In terms of the key vacancies, I think, boy, it's, we've had a couple, have been very fortunate, and kudos to CHIA's managers that have been managing for transition. And so we have had some senior people leave. For instance, our chief financial officer, Barbara Bousquet, stepped down earlier this year, but her deputy, Bobby LeBlanc, is a long time, extremely high-end CHIA staffer, and so we've been able to really not miss a beat there. So we are going to be posting for a permanent CFO, but in the shorter term, we're really being very well served. So it's not a vacancy that's been hurting us. We have another very senior person who's leaving soon. It'll be a huge loss for the agency, but we're kind of well aware of the of her departure, and she's also agreed to stay on post-retirement in a limited capacity, which will give us access to her knowledge. So that's another huge loss, but one that change happens, transitions happen, and so I think that we're well positioned to manage them. But yeah, a couple of big ones are on the list of people that are leaving, but at least none that are sort of sudden and kind of that we're not prepared to manage too.
Great.
All right, next slide, please. All right, so this is just a brief update on the APCD. We received the full production system in May, and so it's so big and complex. It's there's a lot to test there, and so we're still in the process of kind of wrapping our arms around the system and trying to make sure that it's going to do all the things we want it to do. One of the ways we're doing that is we are using it, actually using it for production purposes now on a pricing project. We're working on a multi-state effort to analyze whether the percent of a hospital's public payers, Medicare and Medicaid, when it reaches a certain point, does it undermine their commercial bargaining power and result in lower rates? And so that's a pricing analysis we're participating in with other states, and we're using the new APCD. So we're very excited about that. In July, it will go back down for really the bulk of the month. Well, the final 3 quarters of data are loaded, but that will bring the data up through March of 2022. So just as of 3 months ago, so much shorter lags than we used to have with the APCD. And we're going to be addressing some performance issues with the front end, which have been, are troubling, but we're also confident that we'll get to resolution. The back end works just fine. If you use, SQL or tools like that, it's perfectly responsive. With the front end, we're going to have to do some configuration changes and other things to make sure that it's as responsive as we want it to be. So that's one of the things we're focused on. But at the end of July, the fully populated system will be up and available. And so we've started the process of onboarding sister agencies. The Health Policy Commission is furthest along. And to onboard an agency, there's kind of 3 layers involved. Tongue-in-cheek referred to it as BLT sandwich. You've got the business, legal, and technical layers. The business layer for us is analytics, and that's really the most complicated thing for onboarding agencies to understand at this point. The system is still quite raw. There's a lot of enhancements that we want to add to it that'll make it even easier for ordinary analysts to use, but there's a bunch of discussions we have with onboarding agencies around the analytic use of the system. The legal layer is non-trivial, but it's never a hurdle. We do have legal agreements in place with any agency that's going to be using the APCD, a data use agreement essentially, so that we believe in data sharing, but we also believe that it needs to be documented carefully. So there is a data use agreement. And then lastly, the technical layer involves how people are able to access the system, and that's through an Azure virtual desktop. It's really very elegant and streamlined, and CHIA's staff are accessing the system the same way sister agencies are and seeing the same data that sister agencies see. So anyway, we're working through the business, legal, and technical layers. The Health Policy Commission is farthest along, but we're also talking to Mass Health. We're talking to the Department of Public Health. We've had some good conversations with the State Auditor's Office. And just recently, the GIC reached out to us wanting to understand what we could show them at a more granular level about relative prices. And of course, the APCD is the premier tool for seeing relative prices because you're actually seeing the true prices paid by the health plans to the providers. So anyway, look, things are looking good on the onboarding front. That'll pick up later this summer once the system's back online. And so our primary areas of focus at this time are performance, really just with the front end. We want to get that to it's never going to be instant as if you're working off of a small spreadsheet, but it involves delays that we find unacceptable right now. So we're trying to get to the bottom of that and eliminate them. Documentation, it's a big, complicated system. There's a lot of documentation. We want to make sure it's all finished. And then I think we have to figure out how to roll that up into something that's a bit more accessible. And that gets at this issue of training and support, making it easier for people to onboard without having to understand the full complexity of the system. And part of that is creating templates and data marts. Right now, because we didn't want to constrain we wanted to create a drag and drop front end, but we didn't want to constrain what people could do with it. So right now there's literally hundreds and hundreds of data elements that you can choose in this visual front end. What we'd like to do is create templates so that if you're going in to do enrollment analysis, you're, pre-selected for you are the fields that are necessary for that type of analysis. If you're going in to do a pricing analysis, pre-selected are the fields that are necessary to do a pricing analysis. Because right now, it supports all types of analyses by anyone for any purpose. And that just is daunting complexity, when you're an analyst and that's what you are confronted with. So anyway, it's all good, but we're working on, these things to try to take it to the next level. And then lastly, before turning it over to Emma, I will say, I don't have a slide on it, but it's, all of our major data assets are being upgraded in some form or fashion right now. It's, CHIA has been, we worked really hard during the pandemic to accelerate data collection and reporting in a number of areas. We started a bunch of new data collection activities, and we're now, further refining what we do. You're going to see some interesting presentations shortly that come off of survey data that CHIA does. We're getting ready to stand up a workforce survey, which would be a third survey, which is very exciting. In the area of aggregate data, we've done a lot of work with primary care and behavioral health expenditures, and we're going to be publishing a report later this summer that shows a lot of detail on primary care and behavioral health spending in the state, which has never been seen before. We're responsive to the concerns of the health plans, and so we're continuing to hold off a little bit longer, but we are very eager to start collecting total medical expenditures at the census block group level. That's something that is going to enable some really powerful and important analyses, and so we're committed to moving forward with that. A lot of good progress recently on race, ethnicity, and SOGI data, sexual orientation and gender identity. The state is closing in on standards, and once those standards are in place, then hospitals and health plans will be incentivized to collect that information and submit it to the state. So we'll finally get a much better picture about health equity issues in the Commonwealth. And I guess I'll stop right there, but just wanted to make the point that in addition to these major improvements to the APCD, several of CHIA's other major data assets are also getting significant improvements right now. So it's an exciting time, but we're looking forward to putting these new tools to use. But I will stop there unless, or let me pause for any questions that people have on the executive director's report, and then I'll turn it over to Emma for an update on publications and legislation.
Great. We have been talking about the APCD for a very long time. It looks like we're in the home stretch, if I'm understanding you correctly, which I hope. Do you have any idea, and I'm looking for questions from other board members who've been sitting in on APCD presentations for many meetings. This is in the category, I think, of good news, but we have a bit left. And if I understand it, we have to work on the delays, we have to look at documentation, we have to look at data marks, how we do this. So do we have any idea when this actually might be moving out of what I'm calling, sort of the putting together and moving into, okay, we just have to, the house is built, now we just have to maintain it.
Right. I would say essentially the end of July.
Oh,
it is done now. It's just that there are 9 months of data that's not in the system. So that's being, added in July. And every time data is added, there's a pretty significant process of kind of reapplying all of the groupers and all the logic that gets applied to the claims. It's not just uploaded. There's lots and lots and lots of logic that then gets applied to it. But anyway, end of July, the system comes back and we're good to go. But as I said, to a typical analyst, it will present just daunting complexity still. And so we are now trying to think through what we would do. And we've had lots of ideas around user groups, around monthly meet and greets, which we're calling Smeet and Greets, a bunch of different things that we can do to try to, support the users. But we just know that's the next frontier, is that it's a lot.
So any other questions from the council members? And Laura is going to have to drop off. She let us know in advance. Thank you again for coming as long as you can.
Thanks. That's meet and greet. I'm glad I stayed on long enough to hear that, because that was fun.
It's just worth it for that nugget.
There you go. Thanks, Laura.
Any other?
Ray, as the EAPCD is now getting its final stages, it's really exciting. Are you doing any outreach to let potential users know about kind of the status, I guess, sort of on these discussions, or are generally kind of agencies that want to train up their staff or are seeking you out and you're sort of setting those up one-off?
It's, a little bit of both. We're kind of starting at the sort of the inner, or what are the most logical kind of, it's very raw. You have to have some expertise with claims data and a willingness to, tolerate a complicated system. And so the Health Policy Commission has just been a natural partner as the first onboarders. They're very sophisticated, but Mass Health, similarly, they've got a data warehouse for claims. They just can't see anything but their members. And so we've been talking to them. The State Auditor's Office also works extensively with claims data. So they're a natural candidate. The other ones that occur to me, the Group Insurance Commission, they've got 400,000 plus members, and I know that they've got a warehouse. And so I think they've got, that kind of ability they have analysts that could sort of look at the world that way. Same with the Connector Authority. They've got, several 100,000 members, or 150,000 members, I've lost track. And so I think that they're a natural candidate. And then the last, I would say, Division of Insurance, we've had discussions with them. I think that's probably a little bit further down the road, but that, I think I know they have analysts, that actuaries and such, that have the sophistication. I think it's, I think eventually those uses will come. So anyway, I guess it's been more a sense of, who the likely early adopters would be. But if the Attorney General's office is interested in a discussion, as I said, we've met with the auditor's office.
Yeah, thanks for that, Ray. I'll follow up with you offline. It's a great invitation.
Okay, great. Yeah, no, we would absolutely like it. It's specifically designed for multi-agency use. And so that's really the key success factor here, is how much it's being embraced and used by agencies that, need health data. Great.
Let me add to Sandy's question. What about researchers and others?
That'll be the next frontier. So because of all the the data is much fresher now because of the new platform that we're on. And so we'll be able to provision data to researchers that's much more current than in the old world. We used to wait and produce an annual version of the APCD. So until the next year's version came out, there was a year between versions. Now it's only a quarter between versions. So we can provision data much more rapidly. But also a lot of what we've done here is added groupers to the data. So you can actually see inpatient, outpatient, episodes, risk adjustment, all those types of things that don't exist on the claim line. And so what we'll be able to provision to researchers is a lot richer than it ever was before. Eventually, I'd love to be able to see if there's a way to actually let them onto the platform with the right security and have them directly access the data. But I think for a while, we'll still be shipping cuts of data to them, but it will definitely benefit from being a lot fresher and having a lot more enhancements on it.
So they won't have the ability at any point to be able to work with it in the way that you've described the agencies do, or is it just a matter of time?
Just a matter of time. Just a matter of time. And I think the next layer might even be sort of the state works with certain organizations, including researchers, on a particular initiative. Like we work with researchers on an analysis of readmissions, or, Mass Health might have certain researchers they're working on a health equity thing, whatever. Permissioning these sort of researchers or consultants or whatever onto the platform as, kind of for a one-time use or for a particular purpose, learning how to do that. But then there might be right, the ability to have kind of more long-term onboarding for third parties. Anyway, we haven't gotten there yet, but that's definitely, we have that in mind. We don't want to stop with just this inner ring.
Okay.
And sorry, Sandy, just to kind of like piggyback on what Ray was saying, I do want to say that, like, it's been a very positive experience for our office, like working with CHIA, like, starting this onboarding process and anything. So I do highly recommend any other agencies that think they'd be interested in this data to definitely contact Ray and contact CHIA and hop on. So yeah.
Thanks, Rob.
It's great.
No problem.
Other
All right.
questions? I think that's it, Ray.
All right, great. Thank you very much, Ray. Then I will turn it over now to Emma Schlitzer. Alex, I think maybe, run the slides forward and take it away, Emma.
Great, thank you, Ray. I'm going to provide a brief legislative update. So last Thursday, the House unanimously passed an act addressing barriers to care for mental health, which complements the Senate mental health bill that passed in November 2021. Overall, the bill focuses on youth behavioral health needs. It includes provisions to address emergency department boarding, requires coverage for annual mental health wellness exams, language to implement the new national 988 mental health hotline, and policies around workforce recruitment and retention, among other sections. Regarding CHIA specific sections, the House bill largely mirrors the language that was included in the Senate legislation. If passed, it would task CHIA with defining and categorizing behavioral health services, including specific subcategories, as part of the agency's continuing programs of study. It would also add analysis of behavioral health expenditures and services to CHIA's annual report. The House and Senate bills now head to a conference committee to reconcile the two versions of the legislation. And just as a reminder to the Council, formal sessions will conclude on July 31st. So we will be closely monitoring this legislation status and any additional healthcare bills that might progress over the next 6 weeks. Next slide, Alex. Great. So now I'm just going to pivot and walk through publications that have been released recently, followed by a look ahead to what's coming up next.
Could I ask one quick question for the council? And that would be, do any of this work that you just described for mental health require additional resources or put a strain on CHIA staff?
I will let Ray chime in if he thinks so. I don't believe so. So with the behavioral health expenditures and costs and tracking, that's something we've been working on with the primary care and behavioral health expenditure data collection. So it potentially could use some modifying. Like I said, they did lay out some specific subcategories, but I think we feel well prepared to handle kind of any additional responsibilities that come from that bill.
Yeah, great answer, Emma. That's, we really try very hard to skate to where the puck is going to be, because the data stuff, is something, there's long lead times and you'd like it to be ready when you start looking at a policy area. And so primary care and behavioral health spending is one of those that even though there hasn't been legislation passed yet that would require us to measure that or to create incentives around that, we're going out for our third year of data collection on this. And so in creating the specifications for primary care and behavioral health spending, we've got quite good at kind of understanding what goes into it, how to parse it, how to make the buckets mutually exclusive, how they roll up, so on and so forth. And so if the legislature directs us to do this, we feel confident we could do it quite easily.
Thank you.
Thanks, Ray. So touching on publications, since our last council meeting, we have released the second report in our healthcare equity series, this time with a focus on geography. This report provides a baseline assessment of gaps in health insurance coverage, access, utilization, and affordability across 8 health service regions by utilizing 3 waves of the MHIS. Earlier this month, we also released summary results from the 2021 Massachusetts Employer Survey, also known as the MES. The MES tracks and monitors employer health insurance offerings, health insurance premiums, plan characteristics, and employer decision-making. And you'll be hearing about both of these reports in greater detail later this meeting. We also published FY20 hospital profiles, which provide a comprehensive look at hospital and health system performance metrics, and a preliminary FY21 financial performance report. This report provides a view of profitability, liquidity, and solvency for hospitals with a fiscal year end of June 30th or September 30th, which is a majority of Massachusetts acute hospitals. And we will release an updated FY21 report when data from hospitals with a December 31st fiscal year end date becomes available. Additionally, we have posted to our website national healthcare data statistics, which uses several publicly available data sources to facilitate comparisons between Massachusetts and the US performance on several key healthcare data points. Next slide, Alex. Great. And then lastly, we released our biannual health insurance enrollment trends report with data through September 2021 and 2 editions of CHIA's newsletter, Data Matters. All right, so now moving ahead to what's coming up in the next few months. Towards the end of the month, we will be releasing the next quarterly hospital financial performance report, and that will have data through March 2022. This summer, we also plan to publish results from the Massachusetts Health Insurance Survey, the MHIS. It's a biennial population-based survey that provides information on health insurance coverage, healthcare access and use, and healthcare affordability. And one data point that comes out of this a lot is the uninsurance rate for Massachusetts. Additionally, we have 2 upcoming publications on provider quality. The first will be a focus on provider quality selected clinical measures that examines performance across a subset of metrics from HEDIS. We will also be releasing a new quality measure catalog, which will include information on which quality measure payers and providers are using in their global budget-based risk contracts and adherence of measures in use to the state's aligned measure set. And then lastly, we will also be publishing calendar year 2020 relative price data that examines provider price variation in the Massachusetts commercial market. All right, up next, there will be the most recent quarterly update on hospital inpatient discharge data with data through March 2022. These quarterly updates use interim data to present analyses on a monthly basis to provide timely patterns and trends on key inpatient utilization measures. We will also be releasing a new report on primary care and behavioral health expenditures that Ray has touched on. This publication will examine Massachusetts spending on primary care and behavioral health services in 2019 and 2020. We are also in the process of wrapping up 2 mandated benefit reviews that were referred to CHIA by the legislature. The first bill would require coverage of medically necessary services provided to individuals who have a dual diagnosis of mental illness and substance use disorder. And the second bill would align state and federal mental health parity laws. And then lastly, we'll plan to release the next installment of Data Matters, as well as 2 data releases from our case mix database. So this is the last slide I have on publication, so I'll pause for any questions. I know that was a lot to cover in a very short amount of time.
And a lot to do.
Yes.
Lots of data.
Great. Next slide, Alex. And then we just want to recognize that CHIA recently has had staff present and lead discussions at events organized by NATO and Academy, 2 of the preeminent national healthcare data and research organizations. So I'm not going to read through this entire slide, but included are titles of the presentations and posters, which display the range of topics that CHIA staff presented on. Any questions?
What does NATO stand for?
The National Academy of Health.
National Association of Health Data Organizations.
Thank you, Ray.
You betcha.
I was close.
I appreciate a good acronym guess. You know.
Exactly. Everybody in government loves a good acronym.
Yes, and so many times you're embarrassed to say you don't know what it is.
Exactly.
All right, so that's it for my slides. So I believe the health equity presentation is up next.
Great.
All right. Why don't I just say, before turning it over to Khalifa and Amy, just point out, we've previously seen highlights from an analysis CHIA did of health equity and disparities in Massachusetts by income and ethnicity. And this continues that work, but looks at health equity through a geographic lens. And CHIA's household survey has very good data on the race and ethnicity of the respondents. And so we do, in fact, in our regular reporting from the MHIS, include reports on, of health equity or demographic variables. The issue is that if you want to combine them and look at both race and ethnicity, the sample sizes get too small to be meaningful. And so in order to drill down like that, our research team did some very sophisticated work to combine multiple years of survey data and reweight it so that you could treat it as a single, almost like they use multiple telescopes to create a single larger virtual telescope. They kind of did a similar technique here with the data, so that using 3 survey periods in order to get enough sample size in order to drill down both on income and ethnicity slices, and in this case on geography. And so we're unaware of, I don't think any other state in the country has done an analysis to this level of detail on geographic variations and health equity. So this is really interesting and important work. And so let me hand it off to Khalifa or Amy, whoever has the microphone first.
Thank you, Ray. Good afternoon, everyone. We'd like to thank the Oversight Committee for inviting Khalifa and me here today to discuss the latest healthcare equity chart book published by the research team. My name is Amy DeSantis, and I'm a senior researcher, and I'm here today with Khalifa Wright, who's one of our senior research analysts on the research team here at CHIA. Next slide, please. Nationally, over the past 2 years, we've seen throughout the COVID-19 pandemic, various subpopulations, including racial and ethnic minorities, persons of lower socioeconomic status, as well as people living in either rural areas or other specific geographic subregions, tend to experience a greater likelihood of challenges related to healthcare services due to a variety of reasons, including lower rates of insurance coverage, limited transportation, fewer physicians and healthcare providers per capita, and the demographic composition of the region overall, among others. Although Massachusetts has consistently had the highest rates of health insurance coverage and tends to have relatively greater access to healthcare services than other states on average, there are notable differences within the Commonwealth in rates of insurance coverage, as well as the likelihood of experiencing difficulties with accessing care, the rates of utilization of healthcare services, and challenges with affordability and unmet healthcare needs. Some of you may have attended the meeting in March when Hong Tru and I presented data from the first chart book that Ray just mentioned, published by the research team on gaps in healthcare related issues by race, ethnicity, and family income. Today, Khalifa and I are following up with some highlights from the second chart book, which focuses on geographic differences in the Commonwealth. Next slide, please. So the analysis we'll be discussing today come from the second chart book in our new series on healthcare equity issues published by the research team that was released in April. The chart book focused on gaps in healthcare related needs across 8 regions of the Commonwealth, and these regions are based on the geographic regions designated by the Health Policy Commission that have been combined into 8 regions in order to increase the survey sample size within each region in the MHIS and thereby increase the robustness of the estimates. Further details on the analysis presented here today, including the complete chart book as well as a data book with further information, are available on CHIA's website. So the data for these analyses come from the Massachusetts Health Insurance Survey, or MHIS, as noted. The survey has been conducted intermittently since 1998, and starting in 2015, the MHIS has been conducted on a biennial basis in odd-numbered years. So the data included in the analyses presented today come from an aggregated data set from 2015, 17, and 19. And soon the research team will be publishing our next report on the results of the 2021 survey, which covers all of the usual healthcare domains, health insurance coverage, access difficulties, utilization, and affordability challenges, as well as new modules focused on the COVID-19 pandemic and telehealth use. Next slide, please. I'll now pass it to Khalifa to discuss the specific measures and highlights from these analyses.
Thank you, Amy. So similar to our previous report, looking at the intersections of health by race, ethnicity, and income, this geography analysis also focuses on 4 key domains: health insurance coverage, healthcare access, utilization, and affordability. For our first measure, health insurance coverage, we focused on whether residents had continuous healthcare coverage for the 12 months leading up to the survey. We next analyzed healthcare access, looking at 3 separate measures, including difficulty finding a provider accepting new patients, difficulty finding a provider who accepted uninsured patients or the resident's insurance type, and difficulty getting an appointment when the patient felt that one was needed. We also combined 3 variables these three variables to create a summary measure identifying if residents had experienced at least one of these access difficulties over the past 12 months. We next investigated healthcare utilization, which was measured based on whether a resident had a visit with a general doctor or specialist in the past 12 months, had a visit with a dental provider in the past 12 months, and whether a resident has a potential reliance on the emergency department or ER. This last measure was defined as residents who had 3 or more visits to the ER in the last 12 months, or that their last visit was for a non-emergency condition. Last, but definitely not least, we measured healthcare affordability by assessing residents' experiences with family medical debt or problems paying individual or family medical bills. Residents were also asked to identify any unmet healthcare needs due to cost, including prescription refills, doctors, specialists, mental health, or dental care. Next slide, please. We analyzed these 4 key domains across 8 regions in Massachusetts. The 8 regions have been defined by the Massachusetts Health Policy Commission based on zip code and include Cape and Islands, Central Massachusetts, Metro Boston, Metro South, Metro West, Northeast Massachusetts, South Coast, and the Western Massachusetts region. Community characteristics of subpopulations across and within these regions, such as residential segregation, community disinvestment, racial, ethnic, and socioeconomic composition, as well as distribution of healthcare facilities and services, may contribute to some of the differences that we've highlighted in this report. We can also see from the chart on the left that there are variations in population density, ranging from 244,000 in the Cape and Islands to nearly 1.7 million in the Metro Boston area. Please note that while our healthcare measures are determined based on the MHIS survey metrics, our overall population estimates are based on the American Community Survey, or ACS, 5-year population estimates to ensure that the population sizes are most accurately represented. Next slide. So our first measure analyzed health insurance coverage across the state. The percentage of residents who reported being always insured for the past 12 months was 93.3%. However, looking across regions, the rates of health insurance coverage range from 89.4% in the South Coast to 95.3% in Western Massachusetts. The regions highlighted in orange on the map indicate where the rate was at least 1 standard deviation below the statewide estimate, and regions in gray indicate those that were within 1 standard deviation of the statewide estimate and thus did not differ significantly from the 93.3% estimate. For example, for those of you who may be interested, the standard deviation for this measure was 0.023. So this means that 1 standard deviation below the statewide estimate was 91.1%, as indicated by the lower threshold on the map key, and 1 standard deviation above is 95.6%. Moving forward, the standard deviation cutoff points will be displayed on the map key, and further information will be articulated in the notes on the slide. As illustrated on the map, the South Coast and Cape and Islands had the lowest rates of residents reporting continuous health insurance coverage at 89.4% and 89.9% respectively. While the percentage of residents left uninsured seems relatively small, this still represents nearly 61,000 residents without continuous coverage across these 2 regions. Next slide. Next, we looked at healthcare access. Nearly 1/3 of Massachusetts residents reported experiencing at least one type of difficulty accessing care at a doctor's office or clinic. As mentioned before, the summary measure includes residents who were told that the provider was not accepting new patients, were uninsured or told that the provider did not accept their health insurance type, or were unable to get an appointment as soon as the resident felt that one was needed. The rates of this measure range from 25.1% in Metro South to 31.2% in the South Coast. For our access measures, regions highlighted in blue on the maps indicate that the rate for this region was at least 1 standard deviation below the statewide estimate. Regions in gray represent those that are within 1 standard deviation, and those in orange represent regions that are at least 1 standard deviation above the statewide estimate. As shown on the map, residents of the South Coast and Cape and Islands reported the highest rates of any difficulty accessing care at a doctor's office or clinic at 31.2% and 30.1% respectively. Next slide. When we separate the summary variable and look at the individual access measures, we see that 12.1% of residents were told that a doctor's office or clinic was not accepting new patients. Across different geographic regions, the rates range from 10.4% in Northeast Massachusetts to 13.3% in the South Coast. Residents in Metro Boston and South Coast reported the highest rates of difficulty accessing care on this measure at 13.2% and 13.3%. Next slide. Our second access measure assessed residents who had difficulty accessing care because they were uninsured or were told that the doctor's office or clinic did not accept their health insurance type. The rates of this difficulty range from 10% in Northeast Massachusetts to 14.1% in the South Coast, which reported the highest rates of residents unable to access care due to this barrier. Next slide. Our last measure of access assessed residents who were unable to get an appointment at a doctor's office or clinic as soon as they thought that one was needed. Overall, 18% of residents reported experiencing this difficulty. By region, the rates range from 15.4% in Metro South to 20.2% in the Western Massachusetts region. This is the only measure analyzed where Western MA had a rate that was greater than the statewide estimate, possibly associated with distribution of healthcare facilities and providers in that region. Residents in the Metro West and Metro South reported the lowest rates of this difficulty at 15.6% and 15.4%. Next slide. Our next healthcare domain investigates healthcare utilization, starting with the rates of visits to a doctor. Overall, 88.9% of residents reported that they had a visit with a general doctor or specialist in the past 12 months, ranging from 87.7% in Metro Boston to 91.5% in the Northeast region. For this measure, regions in blue indicate those with rates at least one standard deviation above the statewide estimate, and those in gray were similar to the statewide estimate. Residents in Northeast Massachusetts, South Coast, and Metro West reported the highest rates of visiting a doctor at 91.5%, 90.5%, and 90.4% respectively. This measure is particularly unique because a high frequency could mean that there's an increased need due to chronic illness, for example, or simply increased access to preventative services. Although the frequency of needed healthcare visits varies by age and health status, the rates of doctor visits over a 12-month period still provide us with an important insight into healthcare utilization trends across the population subgroups. Next slide. Similar to the rate of doctor visits, analyzing dental care provides unique insights on healthcare utilization trends, especially considering that most dental services are not typically covered by health plans. Across the Commonwealth, nearly 3 in 4 residents reported a visit with a dental provider. However, when analyzing by region, the rates range from 68.7% in the South Coast to 76.7% in Metro West. Once again, regions in orange represent where the rates of dental provider visits are at least one standard deviation below the statewide estimate, and those in blue highlight regions where the rate is above the statewide estimate. Rates of dental visits were the lowest in Cape and Islands and South Coast at 70.3% and 68.7%, and highest in Northeast Massachusetts and Metro West at 76.2% and 76.7% respectively. Next slide. Our last measure of healthcare utilization investigated potential reliance on the ER. 14% of Massachusetts residents reported that their last visit to the ER was for a non-emergency condition, or that they had 3 or more visits to the ER in the past 12 months. Across our 8 regions, the rates range from 10.4% in Metro West to 23.4% in the South Coast. Cape and Islands and the South Coast, highlighted in orange, represent the regions that were greater than the statewide estimate at 23.4% and 18.4%. Next slide. Next, we analyze issues with healthcare affordability, highlighting challenges that residents face with the high cost of healthcare. Nearly 1/4 of residents in the Commonwealth reported experiencing any unmet healthcare needs due to cost, including prescription drugs, doctor or specialist care, mental health services, or dental care. Across the Commonwealth, the rates range from 21% in Cape and Islands to 31.3% in the South Coast, where residents reported the highest rates of any unmet healthcare needs due to cost, as highlighted in orange on the map. Next slide. Our second measure of affordability assessed difficulties paying for care at the family level. 22% of all residents reported that their family had medical debt or experienced problem paying medical bills over the past 12 months. Across our 8 regions, the rates of this difficulty range from 18.3% in Metro Boston to 27.2% in the South Coast. Regions in blue on the map have rates that are a standard deviation lower than the statewide estimate, and those in orange indicate rates that are higher than the statewide estimate. Residents in Metro Boston reported the lowest rates of medical debt and problems paying medical bills in the family, whereas those in Metro South and South Coast reported the highest rates. Next slide. In summary, although Massachusetts has an overall high rate of health insurance coverage among its residents, rates differ by geographic region. In addition, the rates of difficulties accessing care at a doctor's office or clinic were lowest in the Metro South and highest in the South Coast region. Utilization measures also varied significantly by region. Most Massachusetts residents reported having visited a general doctor or specialist in the past 12 months, for example, but still nearly 1 in 4 South Coast residents had potential reliance on the ER. Lastly, our analysis has shown that regional affordability issues persist despite high rates of insurance coverage across the Commonwealth. This analysis is only the first step in analyzing these healthcare metrics across geographic regions. CHIA will continue to monitor developments in these domains for different populations, with the goal of using insights from this data to help better inform target interventions for a more equitable healthcare system across the Commonwealth. And now I will pass it back over to Amy to discuss what is next.
Thank you, Khalifa. So the analyses presented in these talks provide a broad overview of the geographic differences at a very high level. The research team plans to next analyze geographic health disparities in greater depth in the future. Specifically, we plan to look at more nuanced details of the healthcare gaps across regions on a smaller scale, as well as investigate the community level factors that may contribute to geographic differences in experiences with the healthcare system. In addition, we have a number of upcoming research briefs focused on healthcare equity issues, including one on racial ethnic differences in potential reliance on the emergency room after adjustment for other key factors that may explain these gaps, and a second on gaps related to citizenship status in the various healthcare domains analyzed in the first 2 chart books. Finally, as mentioned, the summary report of the latest 2021 MHIS survey will be published next month, with new modules on the COVID-19 pandemic and telehealth use, as well as all of the domains typically included. So please be on the lookout for that. Next slide, please. We thank you for your attention today, and we welcome any questions that you may have.
Great. Comments, questions from the council?
Amy and Khalifa, that was awesome. That was really good.
Thank you, Ray.
Thank you.
Yeah, that was super interesting. So it seems like the South Coast is struggling a little bit.
Yes.
So, yeah.
Yeah, I love it because, you know, they have the highest rate of visits, but the most unmet needs. So help. You know, it just raises 1,000 more questions. And I guess
we definitely noticed. Oh, sorry. We definitely noticed that and thought, you know, we can only speculate at this point, but we do know it's the area with the lowest, you know, the highest poverty rates, the lowest average socioeconomic status, and higher than average number of communities of color, which we, you know, we need to do further analyses to understand better. And that is our next step. But for now, we kind of think that those things kind of play into it, as well as far as the higher rates of you know, ER use and unmet needs. There tends to be lower rates of preventive care use, potentially leading to, you know, the use of ER, and visits to the doctor can be, a positive or negative thing, depending on whether they are preventive visits or the result of being in poorer health, which we've also seen. If you look online on the data book, we can also see there are a greater percentage of people who report being in fair or poor health in those regions as well. So we're definitely excited to pursue this further and look at some of the covariates and other factors that might explain the differences, but it's definitely, the take-home message is definitely that. Thank you.
Other thoughts? Because I have a question. CHIA provides data. This is fascinating. I mean, you could spend hours looking at all this stuff and writing 1,000 questions, which I'm sure you guys do. So who takes it from here to actually do anything with it?
I would say the Health Policy Commission, Executive Office of Health and Human Services. The Connector Authority is always very interested in any of our analyses about affordability, access to care, and things like that. In fact, I think coming up, there's a brown bag lunch where we've got analysts going over to do a presentation to Connector Authority staff. So really, we think of this as just the first step. And in a lot of ways, it's the secondary users that are, it's every bit as interesting because they're the ones that can do policy interventions. We're just teeing it up.
Yeah, and I think that's our role, which I think is great. And I think it's just a terrific report. I think that at some point it might be helpful for the council to actually say, okay, now who actually used this? And what were the results? Did something happen that was good? But a hard one to answer, I know. And probably not really us, but maybe everybody else can think about it on this call as well.
It's a great point. And we do have a good sense of our data users. And one of our newsletters tries to always focus on a data user. But maybe we could, let us take that away and think about if there's a way that we can talk more, either with metrics or by narrative, talk about kind of this, what happens to our data after, CHIA has initially compiled it and curated it.
Yeah, we do. We say, okay, this has been used by the Health Policy Commission, but some of us then don't have the wherewithal to then make a connection, says therefore they changed this policy or they implemented this or they did that. It'd be very helpful.
Great suggestion.
And very hard. I do know that.
Right. All right. Any other questions for Amy or Khalifa?
Employers.
Excellent. Well, great job. Thank you so much.
Thank you guys. It's fascinating.
All right, we're going to switch. Actually, just coincidentally, both presentations this week are from CHIA's research team involving surveys and survey data. And it just kind of, whenever we talk a lot about the APCD, the whole annual report is taken from aggregate payer data. There's a lot we do with provider financial data, but survey data is really important. Actually, just an embarrassing side note. When I first came to CHIA, when I didn't understand the value of it, I actually made the comment, well, do we really need to do surveys? Yeah, we really need to do surveys. I'm sorry I uttered those words out loud. But anyway, so really cool stuff comes out of survey data. And this next one, you're going to see a report on the Massachusetts Employer Survey. Employers are such a crucial part of how people get healthcare, health insurance in the state, that understanding the dynamics of that market is really important. And so let me turn it over to Hong Tru and Bridget Geyer for them to talk about CHIA's most recent employer survey.
Hello, thank you very much, Ray. My name is Hong Tru. I'm a Senior Director of Research here at CHIA, and here with me today is Bridget Geyer, our Associate Manager, and together we will walk you through some of the highlights from our Massachusetts Employer Summary Report. Next slide. To begin with, I will share some background about the MES. So this is one of our ongoing surveys for the state, and it really is a survey of private sector of employers with 3 or more employees in the Commonwealth. And we've been doing this survey on and off since 2011. And since 2014, this survey, along with MHIS, has also turned into a biannual survey to really try to track trends and such going on in the employer-sponsored insurance market. And so the survey results that you are seeing is actually supposed to be from our 2020 MES. But, data collection for this survey cycle did begin in March, around February, March of 2020. But however, as everybody knows, because of disruption caused by the COVID-19 pandemic to Massachusetts businesses, data collection was paused that year. And the multiple surges of COVID-19 and challenges in data collection due to the changing business landscape did result in this survey being fielded from May 2021 to January of 2022. So some of the topics that we normally cover in the MES do include kind of the offer, take-up, and coverage rate for the state in the ESI market, as well as cost sharing. So really going into premiums for different insurance plans, as well as out-of-pocket max and deductibles for different types of plans, and what is the employee's contribution in all of this. We also ask employers about what types of plans do they offer to their employees, as well as enrollment by their workforce. Additionally, we also survey employers about what is their decision-making process, what factors do they think about as they're thinking about cost controls, as they're thinking about different plan designs to offer to their employees. And we usually do reserve a section in our survey for emerging topics. And of course, in the 2021 cycle, the topic of the day is definitely the impact of COVID-19 pandemic. So next, I'm going to turn it over to Bridget to walk us through some of the highlights from the survey.
Thank you, Hong. To start, I will describe the populations that the MES gathers data on. So our sampling plan allows for analysis at 3 levels: the firm, the worker, and the workers that are covered by employer health insurance. And this chart shows the distribution of these populations in Massachusetts by firm size. The darkest blue represents large firms that have 200 or more workers. As a count of all firms, these largest firms represent only 4%. However, you can see in the second column that workers at large firms represent 64% of all workers. Similarly, looking at the total number of workers covered by insurance, 69% work in these large firms. The lightest blue area represents the smallest firms with 3 to 9 workers. While these firms represent 56% of the count of all firms, workers at these firms represent only 7% of all workers and 5% of covered workers. The statewide estimates that we present today take into account these distributions. For example, when we present estimates on firms, these estimates are highly influenced by small firms, as they represent the majority of firms in Massachusetts. In contrast, when we present estimates on employees or covered employees, these are influenced heavily by large firms where the majority of employees work. Next, I will walk us through some of the key findings from the 2021 MES. Next slide. Thank you. So the offer rate is the percentage of firms that offer health insurance to their employees. It is a commonly used measure to assess the availability of health insurance in the employer-sponsored insurance market. And essentially, the higher the rate, the better. As I mentioned, small firms make up a large portion of all firms in Massachusetts. You'll notice that the overall offer rate looks a lot like the small firm offer rate. And here we compared the statewide offer rate of 74% to the nationwide rate of 59%. And since virtually all large firms with 200 or more employees offer insurance in Massachusetts and in the US, all firms who do not offer insurance are small firms with 3 to 199 employees. The 100% offer rate among large firms can be attributed to the employer mandate, which by the Affordable Care Act requires firms with 50 or more employees to offer health insurance. And in Massachusetts, while we have a higher offer rate among small firms compared to the nation, still nearly 30% of small firms do not offer insurance. Next slide, please. This slide shows the eligibility, take-up, and coverage rates for Massachusetts employees in 2021. And first, I will describe what is being portrayed in the chart at the top of the slide. The full height of the dotted bar represents all employees. The bolded outline bar is the percentage of employees that are eligible for insurance. And the colored in portion of the bar represents employees that are enrolled in their firm's insurance. The eligibility rate is the percentage of employees eligible for their employer's insurance, and ineligible employees tend to be either part-time or in a waiting period for their eligibility to begin. The take-up rate is decided by the eligible employees whether or not to enroll in insurance. And the coverage rate is the percentage of all employees who are enrolled in their employer's health insurance plan. In 2021, 76% of employees were eligible for insurance, and 70% of these eligible employees enrolled, resulting in a slightly lower take-up rate statewide than the national take-up rate of 77%. Among Massachusetts firms that offered insurance, about half of all the employees, or 53%, received health coverage. And we refer to this rate as the coverage rate, and this is represented on the chart as the colored in portion of the bars. Workers who do not enroll in their employer's health plan may receive coverage either through a family member's employer, the Massachusetts Health Connector, public programs like Mass Health, or may be uninsured. Next slide, please. This slide shows the number of health plan options offered at Massachusetts firms by firm size. The dark blue color represents firms offering only one health plan option, which is about 2/3 of all firms, or 64%. Large firms are less likely to offer only one plan, at 17%. Large firms were most likely to offer two plans, at 34%, and were more likely to offer 3 or more plans compared to small firms. Next slide. This slide shows the distribution of enrolled employees in Massachusetts by the plan type that they are enrolled in. So at both large and small firms, the largest share of enrolled employees were in a PPO, and this is shown in the light blue color. The second most popular plan type was HMO, shown in the dark blue color. And at large firms, 1/3 of enrolled employees were in a POS plan at 32%. Next slide. Another important plan type to consider is the high deductible health plan, which includes health plans with a deductible of $1,400 for single coverage or $2,800 for family coverage. And starting at the top of the slide with the horizontal bars, these numbers are new for 2021 and help to quantify the availability of high deductible versus non-high deductible health plan options at Massachusetts firms by showing the percent of firms that offer only high deductible plans, shown in dark blue, those that offer a high deductible and a non-high deductible plan, shown in light blue, and those who do not offer a high deductible plan, shown in gray. Among firms offering insurance, more than half of small firms offered high deductible health plans exclusively at 56%. Large firms were more likely to offer both a high deductible and a non-high deductible plan at 44%. Now moving on to the bottom of the slide, if you could just go back to that, thank you. To the bottom of the slide, we show the percentage of firms offering high deductible health plans and whether a savings option is also included. So savings options include a health savings account or a health reimbursement account. These accounts may help to alleviate the impact of that larger deductible. As you can see, the overall offer rate for high deductible health plans did not differ substantially between small and large firms. However, large firms were much more likely to offer an accompanying savings option with their high deductible health plan at 65% compared to 30% at small firms. Next slide. This slide shows the percent of enrolled employees that are in a high deductible health plan. Nearly half of Massachusetts covered employees, or 46%, were enrolled in an HDHP. For both small and large firms, most covered employees who enrolled in a HDHP were enrolled in a plan that offered a savings option. However, at small firms, nearly 1/4 of covered employees were in a high deductible health plan without a savings option. Next slide. The MES collects robust data on health plan cost share, and this slide shows the premium data for single coverage for 2021. The average monthly premium for single coverage in Massachusetts was $715, higher than the national average at $645. Massachusetts employees contributed 25% on average compared to their national counterparts at 17%. Both in Massachusetts and nationally, employees contributed a similar share to their premiums as small and large firms.
That's pretty striking.
Yeah.
I wouldn't have guessed that. I would have expected there to be more of a differential. So Remember, I started.
A differential between the small and large firms?
Yeah, between the small and large plans in terms of contribution rates.
Right, yep. You do see, the slight difference between the total premium amount between small firm and large firms.
Oh,
But the actual percentage is pretty comparable.
thank you.
And next slide. So new for this report, premium data was collected for 3 distinct categories of family coverage: employee and dependent children, employee and spouse, and employee and spouse and dependent children. The 2021 average monthly premium was $1,397 for employee and dependent children coverage, $1,422 for employee and spousal coverage, and $1,956 for employee, spouse, and dependent children coverage. The average employee contribution for each of these coverage options ranged from 27 to 29% for all firms. Small firms have lower total premiums for family coverage, but require employees to contribute a higher share of the premium. So we do see kind of like the actual contribution amount look pretty similar at small and large firms. And next slide, please. Moving on to another aspect of cost sharing, we have the deductibles, out-of-pocket maxes, and copays. In 2021, the average annual deductible for single coverage was $1,661, similar to the national estimate. And average annual deductibles in Massachusetts were about $200 higher at small firms relative to large firms. And moving to the right corner of the slide, we show the average out-of-pocket limit in 2021, which was $4,267. Again, this is very similar to the national estimate of $4,272. And the bottom table shows the average copays for healthcare services in Massachusetts, and we found that copays for all medical services at small firms were higher than those at large firms. And this was particularly true for emergency department and inpatient visits. Next slide. ED visit copays were about $100 more at small firms, and inpatient visits were about $170 more at small firms relative to large firms. Next slide. And as Hong mentioned, Massachusetts employers and employees have definitely been significantly impacted by the COVID-19 pandemic, and the 2021 MES included new questions to quantify impacts such as changes to employment levels and changes to benefits. So in 2021, 9% of firms furloughed or laid off employees, and 21% of all firms had employees who left voluntarily. And among small firms, nearly half, or 49% of large firms reported that employees who left voluntarily during the pandemic. Next slide. Among firms who had employees leave voluntarily, we asked if they could provide some information about who those employees are. And they reported that workers with children, workers with underlying health conditions, older workers, part-time workers, women, and workers that were close to retirement were most likely to have left voluntarily during that time. Next slide, please.
So can I ask just one quick question to make sure I'm reading the data correctly on the last one? So 33% of the people who left were women, 71% had children. I'm trying to figure out were the rest men with children, I guess. Yeah.
Yeah,
You
so
can have children be anything. So you can be underlying health condition with kids. Got it. Sorry.
right.
I was thinking that was the main reason.
And where it says part-time workers, is that part-time workers left, or is that FTE full-time employees that went to become part-time workers?
It was part-time workers who left.
But can you answer 2 or 3 answers? I could be close to retirement, therefore an older worker, and I probably still have a kid, you know?
Right.
Okay.
Yeah, so, yeah, and the percentages reflect the percentages of firms that reported any of these groups leaving. So they don't reflect, say, the number of employees that left. It's a little bit of a different distribution. So of all the firms, 38% reported that individuals who had left voluntarily were those with children.
So the unit of analysis is firms here, not employees. Okay, got it.
So wait a minute. So 38% of the firms had people leaving because of children.
38% of the firms that had an employee leave voluntarily,
Right.
They noted that they were folks with children. So it's a little bit of a smaller sample size. If you think of all the firms that had anyone leave voluntarily, 38% said it was those with children.
And I also, was it companies with more than 200 employees, only half said they had people leave voluntarily? I don't think so. It's not,
Correct.
it's pretty much 100%.
Right.
They have somebody somewhere, if they have more than 200 employees.
Right.
So, and I think
Yeah.
this may be one where people didn't know how to answer if they had people, doing 2 or 3 reasons. Anyway, it's fine. It's interesting, but I'm not
I
sure.
think I do want to also clarify that as we're asking firms, they're also only considering their Massachusetts employees. So let's say a company like IBM, they could think about nationally, they had people leave, but we only want them to consider for this survey among their Massachusetts employee, what or not they have left, that they were impacted. So I think we did kind of have them do it for those very large firms, that level of kind of like filtering their data for us as well. Does that make sense?
It does, but having answered 1 million surveys, it's not going to be really accurate at that level. It's hard. It's just so hard to figure out of the 25 people in the Boston office,
And I should point out, this is not normally part of the employer survey. This was because we were trying to understand the impact of the pandemic on the employers so we could understand what it was doing to our survey.
Yeah.
This is actually information about the responses of employers during the pandemic that otherwise I don't think anybody else was surveying employers. So it's a little window into that, but this isn't our bread and butter, and it wasn't, designed as a sort of an ongoing analysis.
But it lots of questions, but it's interesting. All of it's interesting.
Great. Well, thank you. I think we can move on to the next slide. Yes. So another data point that was collected new to the 2021 MES was whether or not firms newly offered benefits in response to COVID-19, and how we captured that was based on this time point of March 2020. So in this chart, the bolded color represents the share of firms that offered a benefit prior to March of 2020, and the lightly shaded colored portion of the bar represents the share of firms that offered a benefit since March of 2020, but not previous to that. And the most common benefit that we do have been newly offered since March of 2020 was paid sick leave, with 11% of all firms newly offering this benefit. 7% of firms newly offered retirement plans, 6% newly offered dental insurance, 5% newly offered disability insurance, or a vision plan that was also 5%. So that is what is shown on this slide. And you'll notice that across all types of benefits, large firms were more likely to offer the benefits and to add new benefits over time.
I'm amazed at this point they're adding new benefits. Other than paid sick leave, which makes sense, but why throw in a vision plan if I've never done it? I don't understand.
Right. I mean, then it seems across the board, and
Everybody,
you wonder if the employee retention angle. I'm not sure what it is, but it's striking.
Yeah, it really is. I mean, I've never seen so many ads from everybody on everything.
Everybody adding something, yeah.
Especially when you don't know what the economy is going to look like.
Right.
And you're cautious. Maybe pretend. I don't know. Fascinating. They should have done more childcare, but that's aside. That's the one they needed, folks.
Good point.
Especially when you looked at the reason.
Right.
Absolutely. And if you go to the next slide, please. So this was another additional data point. So we measured other changes in benefits due to COVID-19. And this was since January of 2020. Nearly half of firms, or 49%, expanded access to telehealth, and 18% waived or reduced cost sharing for COVID-19 treatment. And this was especially prevalent among large firms. 75% expanded access to telehealth, and nearly half waived or reduced cost sharing for COVID-19 treatment. Firms also implemented changes to their mental health or substance use policies, with 6% waiving or reducing cost sharing for these services, and 7% expanding the number of providers for these services in the plan's network. And again, these were even more prevalent at large firms. It's just some additional changes and benefits that occurred surrounding the pandemic. And next slide, please. And that's all the data we have time to show, and just wanted to review some of the highlights of the key findings that we presented. So most Massachusetts firms, 74%, offered health insurance to their employees, and at a higher rate than firms nationally. And among firms that offered coverage, about 75% of their employees were eligible, and 70% of eligible employees enrolled, leading to just over half of workers receiving health coverage. Nearly half of employees were enrolled in a high deductible health plan, and over 1/3 were enrolled in a high deductible health plan with a savings option. Average total monthly premium for single coverage was $715. In Massachusetts, this was a bit higher than the national average, $645. And we did see some changes in benefits. So since January, we saw that firms have expanded access to telehealth, waived or reduced cost sharing for COVID-19 treatment, and expanded access to behavioral health services. So what's next? So the MES has a few additional questions that we have not discussed in this presentation or in the current report. And there's additional analyses of the MES that can provide information about subpopulations and can go into more depth on other topical areas. And one example is looking a little more closely at self-funded insurance plans in Massachusetts. And we have some of our research analysts delving into that. And additionally, we are preparing for another round of survey fielding for the MES, expected to commence in 2024.
Lauren, do you have a question?
Yes, and apologies if I missed this, but did any of the data that you collected or capture the influx of individuals enrolled on Mass Health due to the federal rules and requirements around maintenance of effort, which essentially paused redeterminations? Because I'm just curious to know where, if a number of those individuals, if there's any trends that showed a lot of those individuals may have come from large firms or small firms.
Mm-hmm. Yeah, Hong, feel free to jump in, but I don't believe we have that exact data point. I think, it's possible we could look at kind of like the coverage rates over time among different sizes of firms and see how has the coverage rates broadly changed if people are kind of moving into Mass Health. In that way, they wouldn't actually be captured in our survey, I believe. So we would just see that the coverage rate had declined a little bit, might be a way of measuring that. But Hong, did you have anything you wanted to add?
I think that's really the gist of it, that we don't ask employers directly in terms of your employees that's not choosing not to enroll in your plan, where are they going and such. I think we do more ask kind of like firms that are not offering insurance, what are their reasons? And one of the more popular reasons that they could choose a couple options is that their employees or their families covered under another plan. Mm-hmm. So another plan could be the partner's employer's plan, or it could be a public plan. But we haven't delved into the details with employers at this point in time.
Got it. Yeah, I mean, if you just do a comparison to pre-pandemic, the last time that you did the survey, you might be able to glean something from that, just based on if any one of those groups or categories saw sort of a material decline based on the 2021 data. But I think it will, once the redetermination process is back up and running again, following the end of the federal public health emergency, the next time you collect it, we may be able to see the trends there as well, sort of on the back end of it. If we see sort of increases on any one of these categories. So something just to think about, given the dynamic nature of coverage that I think that we will continue to see for the next couple of years.
And on this topic of enrollment, it is, CHIA prides itself on always, or as often as possible, having multiple lenses into any particular issue. So on the topic of these enrollment questions, there's our survey data, but we also collect enrollment trend information from the health plans and compile that into, twice a year we release an enrollment trends report. And so we do track the changes and kind of the growth in mass health because of the pausing of the redetermination. So we track mass health enrollment and commercial enrollment very carefully in our enrollment trends. And then in terms of specific individuals, once before we did an analysis with mass health, looking at people that were on mass health, and then we looked backwards 6 months to see, or new mass health members, and then we looked backwards 6 months into the commercial claims data to see if we could find them there, to see if people were coming from out of state, from employers, leaving, to try to find out where the folks were coming from. And we were actually able to identify a fair number of them and figure out if they were coming from large employers, small employers, and the like. So with any issue, we kind of can bring multiple different tools to bear to try to understand it better. So the survey data doesn't really specifically look too closely at the mass health redetermination, but I think we have other things that could help us see that better.
That's great. Thank you.
Other questions or comments from the council? Terrific, great report. Really, again, interesting, leading to lots more questions.
Exactly. And really, again, it shows just the power of survey data. It really, I've become such a fan of it. There's just aspects of the system you can't get at unless you talk to people and try to understand these crucial issues. So, and this really does feed very directly into the work of other agencies. And so taking your comment to heart, Faye, we will report back next time on kind of some good examples of secondary uses of CHIA's data and kind of what came of it.
Yeah, because we want it to be used. It's great.
Exactly.
That's the point. Okay, are there any other comments, thoughts, suggestions for the team or the reports? Hearing none, do I hear a motion to adjourn?
So move.
Second?
Second.
Thank you. Have a wonderful summer, everybody. Enjoy good weather, and we'll see you in the fall.
Awesome. Thanks,
Thank you
everybody.
so much,
Bye.
everyone.